Is your back pain coming from a muscle, a disc, arthritis, or a nerve? The honest answer is that symptoms alone usually cannot identify one structure with certainty, but they can tell you three things that matter more: whether a nerve may be involved, how the problem behaves, and how urgently you should be evaluated. And there is one important truth about scans that everyone with back pain should understand. I'm a spine surgeon, and I'm going to walk you through what I actually want to know in clinic before I look at the MRI scan. First, let's do a quick safety check. Go to an emergency department now if you develop new trouble starting urination, inability to empty your bladder, new loss of bladder or bowel control, numbness around the genitals and inner thighs, or significant weakness in either leg. Back pain accompanied by unexplained fever or chills also deserves prompt medical assessment, particularly if you're immunocompromised or have recently had a serious infection, injection, procedure, or surgery. Back pain after a significant fall or accident should also be assessed promptly as well, especially if you're older, have osteoporosis, or take medications that weaken your bones. These symptoms do not prove that something dangerous is happening. Most people evaluated for them will not have a spinal emergency, but those are symptoms that need to be assessed in person, not try to be diagnosed from a video. For everybody else, there are three patterns worth noticing. First, where is the pain most prominent? Not necessarily where it began, and not every place that hurts occasionally. When the symptoms are at their worst, is most of the pain in your back, or is most of it in your leg? If the pain is mainly centered in the low back, that is a back dominant pattern. The pain may come from muscles, joints, discs, ligaments, or other structures in and around the spine. But the location alone cannot tell us which one. If the pain is more prominent in the leg, particularly if it travels below the knee or comes with numbness, tingling, or weakness, nerve involvement is more likely. That still doesn't prove that a nerve is involved. Pain from the back can be referred into the buttock or thigh without a compressed nerve. Problems involving the hip, circulation, or peripheral nerves can also produce leg symptoms. And even when a spinal nerve is involved, the symptoms do not tell us why. A disc herniation can irritate a nerve. Narrowing around a nerve can also irritate it. Inflammation around a muscle sprain can irritate it. Occasionally, a problem outside the spine can imitate the same pattern. So, nerve pain is not a complete diagnosis. It is a clue that helps determine what should be examined next. Second, how does the pain behave with movement? You do not need to force your back through a home test. Instead, think about what you have already noticed during your daily life. Does sitting predictably make the symptoms worse? What happens when you bend forward? Stand upright, walk, lie down, or change positions? Does one movement make the pain spread farther into the buttock or leg? Does another make it retreat? This information helps characterize how your back behaves. It can guide an examination and sometimes guide the treatment as well. But a single painful movement does not identify a disc, a muscle, or a joint as being what's causing your pain. There is one related finding that is worth understanding. During a structure examination, a clinician may use repeated movements and observe that pain traveling down the leg gradually retreats towards the back. That is called centralization. When true centralization occurs, it increases the likelihood that a disc is contributing to the pain, but it doesn't prove it. And it is not the same as bending forward or backwards once at home. Everything here is a clue, not a diagnosis. Third is what happens when you load your back over time. This is less about one movement and more about what happens after several minutes. Do standing or walking reliably bring on aching, heaviness, numbness, or weakness in the legs? Do those symptoms improve when you sit down or lean forward, perhaps over a shopping cart, a walker, or a bicycle? When those features occur together, they raise suspicion for neurogenic claudication, leg symptoms that can occur when there is narrowing around the nerves in the lower spine. No single part of that pattern diagnoses spinal stenosis. The combination is what makes it more suggestive. There is also a look-alike that matters. If walking reliably produces cramping or aching, often in the calf, and the symptoms resolve when you simply stop walking and stand still. Circulation needs to be considered. Spinal and circulation-related symptoms can resemble each other, and some people can have both. That distinction may require examination of your strength, sensation, reflexes, pulses, and sometimes additional testing. I have a separate video explaining that difference in more detail. Now, let's address the part of back pain that creates some of the most unnecessary fear, the MRI scan. A scan can show something real that still is not the main cause of your back pain. Words such as degeneration, arthritis, disc bulge, and facet arthropathy sound alarming, but many of these findings become increasingly common as we age, including in people who have no back pain. There was a large study that combined imaging studies involving 3,110 patients without any back pain or symptoms, right? And they found that at age 60, an estimated 88% of those patients had this degeneration. 50% had facet degeneration. And remember, these were people that had no symptoms. That doesn't mean degenerative findings never matter. They can matter enormously when the location and severity of a finding match the actual symptoms and the examination. It also means that the findings have to be interpreted in context. A scan shows the anatomy. It does not detect pain. This is why guidelines advise against routinely early imaging when there is no concern for a serious underlying condition and the results will not change treatment. It is not because the pain is imaginary or not important. It is because immediate imaging in uncomplicated back pain generally doesn't improve the outcomes. It can also reveal common findings that receive frightening names even when they are unrelated to the current symptoms. Imaging is generally useful when it is being used to answer a specific question. Is there significant pressure on a nerve that matches the examination? Is there a fracture, infection, tumor, or another concerning process? Would that result change the treatment being considered? The question is not simply, does the scan show an abnormality? Almost every adult spine eventually does. The better question is, does this finding explain the clinical pattern? And would acting on it help the patient? Let's return to the 4 labels people often encounter. Muscle refers to the soft tissue that moves and supports the spine. Strains and spasms are common, often produce back-dominant pain, and frequently improve with time. But symptoms alone cannot confirm that a particular muscle is the source of your back pain. A disc is the structure between 2 vertebrae, and a disc can also contribute to back pain. And disc material can sometimes irritate or compress a nerve. Arthritis usually refers to degenerative changes in the joints of the spine. These changes become more common with age and are frequently present in people with no pain, as we discussed. Nerve involvement describes a clinical pattern that may include traveling pain, numbness, tingling, or weakness. It suggests that a nerve may be irritated, but it does not explain the cause itself. These categories can also overlap. A disc can produce back pain and nerve symptoms. Degenerative narrowing can also affect a nerve. Muscles may tighten in response to the pain originating elsewhere. Imaging findings can be present, again, and they may not explain why there are any symptoms at all. That is why nothing you have observed during this video assigns you definitively to one of the categories. What these observations allow you to do is to describe the problem more accurately. So remember, where are the symptoms more prominent? What movements or positions change them? What happens after you have been standing or walking for several minutes? Those are useful answers. They help a clinician decide what needs to be examined and whether further testing is likely to change the treatment plan. If your pain is mainly in the back, changes with movement, and is improving from week to week, it is generally reasonable to keep moving within what you can tolerate. That doesn't mean forcing yourself through severe pain. It means continuing ordinary activities when possible, instead of assuming that complete bed rest is necessary. People with acute back pain tend to improve substantially during the first 6 weeks, although symptoms can last longer and recurrence is fairly common. If the pain is mainly in the leg, not improving after several weeks, or is substantially interfering with your walking, your sleep, working, or caring for yourself, then arrange a routine medical appointment. Arrange earlier assessment if you develop progressive numbness, weakness, unremitting symptoms, unexplained weight loss, or if you have a history that raises concern for infection, fracture, or cancer. And remember the emergency symptoms from the beginning. If you have new difficulty emptying your bladder, loss of bladder or bowel control, numbness in the saddle region, or significant weakness in your legs, that means emergency assessment now. Do not wait. Now, getting back to the back pain. Remember, symptoms usually cannot tell you the painful structure with confidence, but they can tell us whether a nerve may be involved, how the problem behaves, and which direction you should go next. That is what I use them for in clinic too. I combine the pattern with a neurologic exam, and then I use imaging when I expect the result to change the decision on what treatment we pursue. If standing and walking bring on leg symptoms that improve when you sit or lean forward, then watch the video on spinal narrowing versus a circulation problem. And if your pain sits low and off to one side, near the dimple above the buttocks, that SI joint may be a possibility. Location alone does not prove it. And I have a separate video explaining how that joint is actually evaluated. I'm working on a few new videos discussing each one of these back pain topics separately and with their treatment options. Hopefully you found this video helpful. If so, please subscribe to the channel and I'll see you on the next one.